Good morning, everyone. I'm Dr. Wang from Changi General Hospital, Singapore. Thank you for attending my session on Ecco-Esp Consensus on Histology of IBD. This will be followed by a live case discussion afterwards. As we have learned this morning, chronic inflammatory bowel disease is broadly divided into Crohn's and ulcerative colitis. And the diagnosis rely on clinical presentation, clinical history, and endoscopy from the clinician, with histology, information and interpretation from the pathologist. Sometimes additional information from microbiology and radiology are also required. In the next 20 minutes or so, I will run through the Ecco consensus on the histopathology of IBD that was published back in 2013, followed by more recent updates on the approach to UC and Crohn's disease that was published separately in 2020 and 2022. And to conclude, there will be case illustrations from the Changi General Hospital IBD MDT to learn how the application on such consensus guidelines can be translated into clinical practice. The European Consensus on the Histopathology of IBD, published back in 2013, is also commonly known as the Ecco Guidelines of IBD for histopathologists. And I'm sure some of you can recognize the more well-known names such as Cord Langner, Gibbers, Neil Shepherd, and Michael Vave. The document includes sections such as procedures needed for the diagnosis of IBD, ulcerative colitis, Crohn's disease, and have included a section on indeterminate, unclassified, and infectious colitis related to IBD. Under the heading of procedures needed for the diagnosis of IBD, there are 7 position statements. Position Statement 1 states that for reliable diagnosis of IBD, a full ileocolonoscopy with biopsies taken from the terminal ileum and 5 sites that include the cecum ascending, transverse descending, and sigmoid colon and the rectum is recommended. So as the pathologist, you should ideally receive biopsies taken from 7 sites from the clinician, and from each site there should at least be 2 pieces of tissue for you to look at. They must be sent separately and labeled with the biopsy site location. Of course, that's not always possible in real clinical practice, such as poor bowel prep and where there is fulminant colitis. And even in such circumstances, the endoscopist should still try to obtain 2 tissue pieces from at least 1 site for you to look at. And from experience, it's usually taken from the rectum due to easy access. Biopsies, of course, should ideally be taken before the starting treatment, because after treatment has started, it may give some healing effect, and that will cause some patchiness in the overall interpretation on microscopy. Depending on the endoscopy unit and the laboratory setup, biopsy can be sent separately using separate containers, like what we do in Changi General Hospital, or multi-well cassettes, which is what is used in Oxford, and the paper strip method. This is an example of a bad request from a clinician for a patient with first presentation of suspected IBD, and it is uncertain whether he has UC or Crohn's disease. As you can see, I've only received specimen from the terminal ileum and what he has labeled as rectosigmoid colon. We are not sure whether he meant that he has taken sample from the rectosigmoid junction, or has he combined biopsies taken from both the sigmoid and the rectum together into one specimen pot. And a third was what he thought might be an inflammatory polyp from the rectal sigmoid region. So for such situations, I will always include in my report the echo position statement 1, that it is a minimum require of 2 biopsies taken from at least 5 sites along the colon, including the rectum, and the terminal ileum should also be obtained, so that he is aware that more biopsies have to be sent to help the pathologist arrive at a better diagnosis or more reliable diagnosis of IBD. The echo position statement 3 states that the biopsy sample should be accompanied by clinical information such as clinical history that includes the age of patient, social history, travel, and extraintestinal manifestation such as fistula, endoscopic findings and images, so that the pathologist can correlate the findings of endoscopy together with what we see under the microscope, history of treatment, and also the duration of disease. This is important because if the biopsy is taken too early, like under 4 weeks, for example, the crypt architectural changes may not be obvious. Position statement 4 deals specifically to surgical resection specimens. It's recommended that they are open along the longitudinal axis for fixation. Of course, it may be difficult when there's tight stricture formation, and then you'll have no choice but to do cross sections instead. The optimum number for how much should you sample from a resected specimen has not been established. For me personally, I tend to do a longitudinal strip from proximal to distal, so I tend to take a lot of sections. But it depends on the individual practice and preference. You may want to do every 10 centimeters as well, but it should actually include all visible lesions and any suspicious area for dysplasia or cancer. Then it should have some normal and background for comparison, and lymph nodes, terminal ileum, and appendix if it is included in the specimen. Then you must give a good detailed macroscopic examination, such as if there's transmural involvement and whether there's fistula, because these are important features that make you lean towards the diagnosis of Crohn's. So these are 2 macroscopic images of resected specimens. The first one here on my left is actually from an ileocecal resection from a patient with Crohn's disease. So I'm highlighting here there's this phenomenon called the creeping fat or fat wrapping. That means the fat goes all around the ileum, and this is an important feature of Crohn's disease. And this one also has stricture formation. That is why it's difficult for me to open completely along the longitudinal axis for sampling. This second one is actually what everyone can recognize, that there is continuous inflammation involving the distal colorectum, and then there's an abrupt transition from normal to abnormal. So all these are supporting features of ulcerative colitis. So after sectioning down the microscope, there are certain features about the ulcer character, right, that can help you distinguish between UC and Crohn's. So for Crohn's, the ulcer is typically described as fissuring ulcers, V-shaped type of ulcer, and the chronic inflammation, as you can see, actually extends beyond the mucosa into the submucosa, and even the ulcer technically usually involves the muscularis propria And the chronic inflammation usually is transmural. That means it involves the muscle layer and even extends into the pericollic fat as well. Then there's the other type, the UC type ulcer, which tends to be more broad-based, like square-shaped rather than V-shaped. So it's broad-based ulcer, and you can even draw a line that is usually involves only the submucosa, doesn't really extend into the muscularis propria. So it's superficial type ulcers. So this will help you favor ulcerative colitis rather than Crohn's disease. So Crohn's disease gives you V-shaped fissuring type ulcers, whereas UC typically is more broad-based, and you have this flat pseudo-inflammatory polyps on the surface. For the remaining position statements on procedures needed for the diagnosis of IBD, I understand, let's say for statement 2, most pathologists are already doing that in the laboratory already, like tissue samples are already sent fixed in formalin. And for GI biopsies, we do not only just examine one level, we look at 3 levels, and when we need, we order more levels. For position statement 5, it is also encouraged that the pathologists give an indication on the severity of active inflammation when seen. So you're supposed to try to grade it from mild, moderate to severe when you see it. We must also know that in Crohn's disease, when there is complete mucosal healing, that means no inflammation, that does not mean that there is no ongoing fibroinflammatory response in the deeper layers such as the submucosa and muscularis propria. And that is why even with mucosal healing in Crohn's disease, sometimes stricture formations still occur, and we are unable to give any sort of indication as pathologists because we are only examining the mucosal aspect from specimens received from the endoscopist. Position statement 6 refers to special group, that means the children and young adults. They do recommend ileocolonoscopy with biopsies taken for if there is suspected IBD. And for children with possible IBD, they should also consider having upper GI endoscopy with biopsies taken from the stomach and duodenum. So for position 7, statement 7, there's no terminology in a way for patients without a definitive diagnosis of Crohn's or UC. But I think that has changed because subsequently in section 7 on indeterminate and IBD unclassified, since the publication of this document, this has changed. And there's more consensus among pathologists. If one cannot make a diagnosis of Crohn's or UC, what terminology or what label you should, diagnostic label you should actually use. So this we will cover later. We will now move on to the next section on ulcerative colitis. Under ulcerative colitis, there are 14 position statements, number 8 to 21. So for position statement 8, it deals with macroscopic examination of the resection. And what I have shown you earlier on, the continuous inflammation that starts from the rectum all the way proximally to the, let's say, sigmoid, and can be pancolitis with a bit of backwash or extension into terminal ileum. That is still UC, ulcerative colitis. That does not make it Crohn's. And then there's also special circumstance situations when you see continuous inflammation from the rectum up to, let's say, the sigmoid, and then suddenly you realize there's a bit of inflammation over in the cecum near the appendiceal orifice. So to you, it looks like a skip lesion. But this discontinuous pattern is also has been observed in ulcerative colitis, and you should not make a diagnosis of Crohn's. So be aware of cecal patch, this word cecal patch in ulcerative colitis. In children, you'll be surprised that they tend to have a bit more rectal sparing. So rectal sparing means that the degree of inflammation is most severe, let's say, in the sigmoid colon and rectum. Even though there's some inflammation, it doesn't seem too bad. So it gives you some sense of a patchiness, and you think, oh, maybe this is Crohn's disease. But in children and young adults, be aware that sometimes they do get rectal sparing. So be careful not to make a diagnosis of Crohn's too quickly when you see rectal sparing. And also get information on the treatment. If the person has been given some enema before the biopsy is taken, you will also have some less intense inflammation, giving you the impression as, under microscope, the rectum may not seem as inflamed. So you think that it's rectal sparing. So always check whether the patient has already been given some treatment before, like let's say an enema, and that's why there is less inflammation in the rectum compared to the sigmoid colon. Moving on to position 9, actually that gives the full microscopic description of what is seen in ulcerative colitis. So you expect to see widespread or diffuse crypt architectural distortion, a diffuse transmural inflammation infiltrate with basal plasmacytosis, and then there is active inflammation, classically described as cryptitis and crypt abscesses. Mucin depletion, we like to describe it, but it's actually less specific, but may be useful sometimes. So not to worry, this is all a lot of words, but I have to go through the document. We will see a lot of these examples in the case discussion later. So first thing is widespread crypt architectural distortion, a dense chronic inflammation in the mucosa from top to bottom, and with basal plasmacytosis. So statement 10 covers basal plasmacytosis. It's used as an earliest diagnostic feature. Because if you rely on crypt architecture to make a diagnosis of UC, please note that it may not be obvious if the biopsy is taken less than 4 weeks after the onset of symptoms. It's more reliable after 6 weeks. Then you can see all the crypt architectural change and basal plasmacytosis. It is known that basal plasmacytosis is probably the first clue you will see on the glass slide that it may be IBD. And then the crypt architectural changes only happen usually after 4 weeks. Now, position statement 11 deals with long-standing disease. Long-standing disease, whether it's let's say in mucosal biopsies, okay, because the patient have already been on treatment, so you get a bit of what you call an impression that it's not is actually not continuous. That means it's patchy, and that shouldn't make you suddenly say, oh, I don't think this is UC, it's probably Crohn's. So do not change your diagnosis. Be aware that actually long-standing disease with treatment, you do get patchiness, what you like to see as diffuse initially, when you make the diagnosis, that changes over time with good treatment and relapse as well. So just be aware that just be aware of that patchiness can happen over time due to treatment effect, and you should not change the diagnosis to Crohn's afterwards. Okay, so try to not be put under pressure to do so. So statement 12 deals with quiescent disease. Quiescent disease means that there's no more activity. That means after good treatment, the active inflammation is gone. So the word quiescent is used. But in quiescent disease, there may still be some clues that the person have underlying IBD. So active inflammation like the neutrophils, crypt abscesses will tend to go away. That's why it's inactive. But the basal plasmacytosis or the increase in chronic inflammation within the lamina propria and crypt architectural change can persist. Okay, so it's as long as you don't see any active inflammation, then the patient technically is inactive, and we tend to use that as a quiescent disease. Okay, so clues that the person have underlying IBDs is still the same, like crypt architectural change, and basal plasmacytosis may not improve with immediate treatment. Okay, just be so that you're aware of it. So I find this really a helpful document to have to understand the spectrum of IBD and different situations where you can get skip lesion in ulcerative colitis, and should avoid suddenly changing your diagnosis to Crohn's disease. So position 13 just highlights some of the histological features that can help to predict clinical relapse. Moving on to position statement 14, it deals with treatment effect, which also I have briefly covered earlier on. It can result in patchiness, rectal sparing, and also normalization of the mucosa. So for pathologists looking at the biopsies, please check whether the patient is on treatment, and if the patient is on treatment, please give an indication on the degree of active inflammation. If there's still ongoing severe activity, the clinician receiving your report can then decide to step up treatment or change treatment altogether. And if there's improvement to mild, that means from severe to mild, the clinician can choose to make the patient stay on the same drug, but just changing and stepping up the dose, changing the dose. So that's where your report is extremely useful in helping the clinician decide on the management pathway. Position statement 15 deals with CMV reactivation in ulcerative colitis. And this should be suspected when biopsies are received from a patient who is having an active flare of ulcerative colitis with ongoing treatment. So when you see large ulcer or ulcer slough, please look out for CMV inclusion. And even if you don't see any, please also do a immunohistochemistry to confirm. And so for me, my practice is to run a CMV immunohistochemistry, and then when present, I will do a count, let's say 5 example, right? 5 per high power field seen on immunohistochemistry. The clinician can then decide whether it is worthwhile starting on CMV treatment or just treat the UC aggressively, and with mucosal healing, the CMV actually will infection will go away. But in some situation, let's say you've reported like 20, there are too many CMV inclusions, then the clinician will choose to get infectious disease doctor on board to review the patient. So to decide whether to start on treatment for CMV at the same time stepping up treatment for ulcerative colitis. There may be also circumstances that with pan-fulminant colitis, the patient may end up having a colectomy. So these are important factors to bear in mind. So position 16 deals with what we have mentioned earlier on the situation of backwash ileitis. So do not actually just assume any sort of involvement of the ileum means Crohn's disease. With pancolitis in ulcerative colitis with extension in the into the ileum is not uncommon. It can be seen in some adults and children with extensive colitis. Then we've dealt with the term cecal patch or cecal inflammation, where you get a patient with ulcerative colitis when a patient having ulcerative colitis, you notice that there's a bit of cecal inflammation documented in the biopsy. Do not suggest Crohn's disease because it can be seen frequently in ulcerative colitis as well. All right. Then for position 17 to 20, it deals with dysplasia or colitis-associated dysplasia in UC. This is a separate topic altogether, so I won't go into details. But just know that when you see dysplasia is to actually get an experienced pathologist. If an expert GI pathologist is present in the department, you can actually ask the person to confirm your findings because it has it changes the management. It may actually resulting in a patient having to be referred for surgical colectomy. So that is where you need a second pathologist to confirm. As for position statement 18 to 20, it may be slightly out of date now because there's new guidelines coming through. That is actually another topic because today we are actually focusing on the diagnosis of IBD, so I won't go into details. And position statement 21 covers the scoring and situations of pouchitis, so that won't be covered as well. So we should just focus today up to statement 16, and now we shall move on to Crohn's disease. There are only 3 position statements for Crohn's disease. Accepted microscopic features are focal, discontinuous patchy chronic inflammation, focal patchy crypt architectural distortion, and granulomas. Granulomas, when present, are helpful, but as mentioned in statement 24, they are more likely to be seen in children and young adults, and it's about in 20 to 30% of the mucosal biopsies that we see will have granulomas in them. And watch out for the situation of backwash ileitis. Do not just jump to the conclusion that it's Crohn's. It's probably going to be ulcerative colitis. I find this is now a good time to bring in a table from the document as well. So it covers macroscopic examination, which we have briefly covered when looking at the macroscopic pictures. I've highlighted some features like skip lesion, cobblestone pattern are present in Crohn's disease rather than ulcerative colitis. Then features that are less commonly mentioned are like thickness of the wall, fat wrapping, and strictures are more frequently present or increased in Crohn's disease. For microscopic examination, discriminating features for Crohn's disease are patchiness, transmural inflammation, granulomas, neuronal abnormalities. But what I've highlighted in italics, like transmural inflammation and neuronal abnormalities, they tend to be only seen in resection specimens. So you are looking at mucosal biopsies, then you are only left with patchiness and granulomas to guide you. Therefore, it is important to be a bit more careful and get as much information as you can from the clinician, let's say even microbiology and radiology, before making a confirmed diagnosis of Crohn's disease. So we are now into the final indeterminate, unclassified, and infectious colitis related to IBD section. And this I have mentioned earlier on in position statement 7, the terminology to be used for labeling patients without a definitive diagnosis is unclear. And that is why this term, there's more standardization and given a label called indeterminate colitis, and the term indeterminate colitis should only be used when you get a resected specimen and you still cannot tell whether it is ulcerative colitis or Crohn's. Okay, so but if you only have biopsy, you think there's IBD because there's basal plasmacytosis. But there isn't enough to decide whether it is ulcerative colitis or Crohn's. You should use the word CIBD or chronic inflammatory bowel disease unclassified. Okay, so since the publication of this document in 2013, there is more standardization of this indeterminate colitis for labeling patients with indefinitive diagnosis, okay, for suspected IBD. So there are 6 position statements in relation under this section, and which we have actually covered to a certain extent on terminology of indeterminate colitis. And infections is something that we have also mentioned in particular to CMV infection. They can recommend immunohistochemistry or quantitative tissue PCR, and understanding that histology is not good in identifying bacteria. Okay, so there are limitations. So after, you will find that 2013 document is very good. And it covers a lot of details. That's why we are actually spending a lot of time on that, because it covers all the histological features, the diagnostic steps that is required for both clinician and pathologist. Now after nearly up to 10 years, is of course there are a lot of things may have changed as well. So things that they have specifically mentioned is that because of better treatment, people, the clinicians particularly, is interested in understanding mucosal healing histologically. And that's why in the new update on the Ecco's position paper on approach to ulcerative colitis, is that they have recommended the use of, in clinical practice for us, right, the use of non-C histological index to grade the activity score. Okay, so in the past, I mean, most of us still use mild, moderate, and severe, but now we are expected to give a score. So that's essentially it. It's because it's been found to be useful for the clinician. It's been found to predict lower rates of relapse, hospitalization, surgery, and subsequent neoplasia, which is dysplasia and cancer. So this is why it's been encouraged for pathologists to give the non-C histological index information, include that in our report. Similarly, there was an update on Crohn's disease, and you can see I've highlighted only mucosal, and that's only what pathologists technically can do based on endoscopy, right? Essentially, it's the same, but it highlights that Crohn's disease is like what I've mentioned. We have mentioned earlier on. Crohn's disease is not limited to the mucosa alone. There could still be ongoing disease inflammation in the deeper layers of the gut, like the submucosa and muscularis propria. And then particularly in the submucosa, there still can be ongoing fibroinflammation causing stricture formation. but they did mention that that Crohn's disease mucosa may not be representative of disease activity, but that shouldn't discourage us. We should still try to give an indication on the severity of activity like mild, moderate, and severe, and scores such as non-C histological index can also still be used, okay? And they have confirmed the presence of epithelioid granuloma should not be considered as a marker of histological activity in Crohn's disease. So active disease inflammation should only be based on neutrophilic inflammation. When you don't see neutrophils, that means in Crohn's disease is actually inactive. If you don't see erosion, if you don't see ulceration and no neutrophils, that means it's inactive. Okay, so specifically, granulomas is not an indication of active inflammation. So you have heard me mention about the non-C histological index under the new Echo position paper on UC. So it's a scoring system used in the assessment of histological disease activity. So for example, it ranges from 0, no or mild increase in chronic inflammatory cells like F, that would be a score of 0. And if there is moderate increase in chronic inflammation, like for example E, without any neutrophils, that's 1. And then for 2, there is actually a few neutrophils that are seen in the lamina propria or the epithelium. So that would be 2. And then 3 is when you see a lot of crypt abscesses in the lamina propria, in the epithelium, and easily assessed. So multiple clusters of neutrophils. So technically that's crypt abscesses. And then for 4 is when you see erosion and ulceration granulation tissue. So it's quite easy to use. And if you get multiple biopsy samples from different sites, only the worst area, right, and the worst feature determines the final score. So if you get 7 sites, you only score it based on the worst area. So why non-C histological index? Is because it's simpler with fewer variables. It correlates with other scoring systems like the robot's histological index. It has been validated. It also correlates with response to change after treatment. It correlates with continuous another scoring system, the Gibbs scores, and with fecal calprotectin levels, and it's actually because of these reasons Echo recommends its use in clinical practice. So now finally, we will then move on to our case discussion, and hopefully we can apply what we have learned from this lecture into clinical cases later on during the live sessions with Dr. DM and myself. Thank you.